Hello, everybody. We are going to resume the rest of our program. I'm going to welcome back Dr. Claus to introduce our next session and speaker.
Hello again. So I'm very excited to introduce our next guest. And I'm going to try to say his name very smoothly and with a good Italian accent, Pierpaolo Peruzzi. He is a colleague of mine at Brigham and Women's Hospital. He is an attending neurosurgeon in the Department of Neurosurgery there. He's also an assistant professor at Harvard Medical School and doing a lot of exciting work in RNA-based gene therapy. He's recently been awarded a very large NIH-funded grant to study this. And so he's going to talk to us a little bit today about the different treatments and also some new ways of thinking about treatment for low-grade glioma. So Dr. Peruzzi?
Thank you very much, Dr. Klaus, for this very generous introduction. But also thank you for inviting me to be part of this very exciting and actually inspiring program today. So my goal today is really to give you an overview of what have been the most relevant advancements in the diagnosis and treatment of low-grade gliomas, and what are the exciting directions that the field is moving to. These are my disclosures, but really none of it really applies to the discussion, for this current discussion. So, as Dr. Klaus mentioned, I am a neurosurgeon, and so as a neurosurgeon, I'm somebody who is regularly in the trenches with, trying to help patients with this disease. And I thought that it probably was a good way to begin this by directly starting with the real patient, and basically, in a way, go through what we as healthcare providers, what goes on our minds as we try to, to accompany the patients through this challenging journey. So the first thing, what happens, this is like the classic day in clinics. There is a relatively, actually a young patient that comes, has been referred by a community practitioner because a week prior, just after a very mild car crash, he had a brain scan, and the brain scan revealed a lesion. And so for this reason, he was referred to me for further evaluation. Then, the first things that we do in these cases, we just get MRI. The MRI is really probably the most important tool that we have at this, this very beginning of patient evaluation. And here is just what that shows. There are clear evidence, the clear characteristic of a low-grade glioma. There are these like basic radiological features. There is this flare sign, which is this kind of whitish area in an otherwise healthy appearing brain, which is like appearing gray. But then also, as we get more information about what's happening in this patient's brain, we give some contrast. And for example, in this case, there is this black region, which in fact is a good thing because there is no evidence of contrast enhancement. Otherwise, this would have looked white, and it would have probably portended a more more aggressive features of the tumor. So at this point, we can have an idea. We are sitting in front of a patient, otherwise completely healthy, with no symptoms, that has something abnormal in this case in his head. And so what we can do, we can interrogate the system a little bit more and start to get some more sophisticated studies. For example, in this case, still based on MRI imaging, this is an MR spectroscopy. And basically, this is just a study where the MRI, there are software basically that allows to obtain a specific molecular signature of these abnormalities that we see in the brain. And for example, as we can see here, there are these peaks. Some of these peaks become prominent when there is evidence, for example, of cellular growth, which is very characteristic of tumors, as opposed, for example, to stroke. There are other peaks that are less prominent than in normal brain, like this one here, because this is a specific marker for neurons And so this is somehow starting to suggest us that, for example, there is this process here that is somehow displacing normal brain otherwise, and that's the reason why we're seeing less neuron signal. But then probably the most important and convincing part is this little peak here, which corresponds to this metabolite, which is called 2-HG, which I will discuss more in detail later. But this is basically a classic signature of actually a very high percentage of low-grade gliomas. So at this point, just by looking at the patient, looking at MRI imaging, we can start having a quite significant suspicion that that lesion there, it's most likely a glioma. It seems like probably a low-grade glioma. So at this point, what we do, the next thing really is surgery. And surgery is basically to accomplish, well, the first goal that you want to accomplish is to obtain a diagnosis. You can have a specific imaging, as specific as you may wish, but still tissue diagnosis remains fundamental to then decide what's going to be the next level of treatment. But then surgery has also another role that it has become clearer actually over the last probably 20 years, because there's been really quite of a switch in the way, and a change, an evolution in the way that we as surgeons, and also the other team treating these patients see surgery in these cases. So the idea, I think it's important to understand in a way the progression of these tumors. Basically, these tumors arise like in theory as a single cell that goes astray. And then the first thing that happens generally is that this cell over time, it increases, it just multiplies itself. Usually it's a very slow process. It takes, sometimes for low-grade tumors, it takes years and years. However, after this stage, in a lot of situations, not all the time, but in a lot of situations, there is, as time goes by, there is also a progression so that these abnormal cells are very prone to accumulate further mutation in their genes. And as these happen, the cells change and they become more and more aggressive, so that then over time, the tumor not only grows in size, but it also becomes more aggressive. And so it grows quicker, it becomes more infiltrative and potentially more symptomatic. So here is what really, from a conceptual perspective, has influenced the role of surgery over the last couple of decades. And so I'm going to cite this study here because at this point, we are really in the surgical field, but not only, we are actually quite convinced that the sooner you actually, the sooner you do surgery for these tumors, the better it is. And there is this very interesting, very actually good study that's coming from Europe, from the Scandinavian region, which shows that basically they compared the outcomes of patients with low grade in two different. They were comparing two different modalities of management, basically. So the Scandinavian studies are great for epidemiological studies because those patients really tend not to really move around too much. And also there were basically two major centers that were collecting all these patients, two major referral centers for these patients. And so it happened that one center was having a more like expectant management approach, meaning that they will just keep looking, keep observing the tumors with serial MRIs and intervene only when the tumor would become either too large or symptomatic. And on the other side, there was the other center that instead will have a more proactive approach. And so basically we'll take these patients to the operating room for a resection as soon as there was evidence of the tumor. And as you can see from these survival graph, patients which had the early resection, they did significantly better. And again, this goes together with this concept that the more you can do to somehow delay this like natural process of progression of this tumor, the better it is for the patient. The second thing that has become also quite at this point really that there is a lot of agreement upon is the fact that the more aggressive you are as a surgeon, the better the outcomes, so the better the survival. This is again, there are a lot of studies suggesting this at this point. It is probably one of those that it enrolled the most patients. And again, here it shows the difference in survival between the patients who had subtotal resection, meaning that after surgery there was evidence at MRI that some of the tumor was left behind, which is the blue line, versus the patients that in fact had an aggressive, as we call, gross total resection, which is the yellow lines. So at this point, for us as surgeons, this opens up like the big question, which is, okay, we know that we have to act soon, and we know that we have to be aggressive. So the question really is finding the right balance, and it's not trivial. And this entails kind of knowing a little bit like what to expect from your patient, from their actually symptomatology. Because one thing that study that I showed you earlier about the one showing that the gross total resection was actually better than a partial resection, that study also showed though that actually up to one every six patients of their cohort, they ended up having some deficits, which is not negligible. However, they also looked at a longer time course, and after 1 year, about 90% of those that had immediate postoperative deficits actually they still had deficits. So the brain has a significant ability to overcome any injuries that can happen, either if it's a stroke or if it's due to surgery. And this is just a patient, just so that maybe I can pass the information a little bit better. This is a patient that I actually operated on just a couple of months ago, and this is how he's doing after surgery.
Is beautiful day.
Good. And now big smile. Okay, thank you so much.
So this is a patient that I operated for a low-grade tumor. He's a young patient. He's 32. The tumor was very close to the motor area, was very close to the speech area. And in fact, as you can see, immediately after surgery, his speech was very slow. He was having problems to articulate words properly, and also he had a weakness in his face. Now, moving fast forward 30 days, just 30 days, this is the same patient.
Today is a beautiful day.
Very good. Now, can you show me your teeth? Very good.
And so, this is really just hopefully to show how much the brain really can improve and over time. And there is really the time for recovery for brain, it can go as high as like 12 to even 18 months. So, in a way, this is an important knowledge for us, for surgeons, because, of course, other than, with the exception of cases where we know that an aggressive surgery really will be devastating for the patient, I think it is always good to keep in mind that in the long term, the best investment that you as a physician can do is to actually try to be as aggressive as possible at the first time. Now, in order to do that, we have a lot of tools that we have accumulated over the last few times, thanks to advancing technology. The first one, for example, is still another MRI. This is called functional MRI. Basically, it works with the same principle of an MRI, but what happens is that as the patient is being scanned, he is asked to perform certain tasks, either to move his hands or to move her legs or to speak, read. And as all the time that these tasks are performed, different areas in the brain lights up and can tell us which are the parts of the brain that are really important for that function. And so that as surgeons, we can decide, can we stay away from those? And so how aggressive can we be? For example, here in this case, this yellow-orange sign here, it shows the activation for the right hand. And this, as you can see, the tumor, this low-grade appearing tumor, is just in front of that area. So again, it's a challenging surgery, but it's a surgery with the due, caution and the due technology, the appropriate technology, you can probably perform. And for example, this is the next thing. This is still on the same patient, basically. The fact that we can actually monitor the function of the brain as we do the surgery. In this way, we can actually have a clear, real-time picture of parts of the brain that are important and parts of the brain that instead are okay to actually go through with a surgical instrument. And by doing that, we can do this either with the patient awake, so the patient continue to talk to us and to do the tasks that we ask the patient to do, or for lesions more located that only really that only are close to the motor areas, we can actually do with the patient asleep and just do all these recordings using some electrodes that we place in the muscles. And then finally, another important adjunct really to try that makes our life easier as surgeons and really to maximize the extent of resection is a tool that actually I use pretty often with these low-grade tumors, which is the intraoperative MRI. So for example, here I'm showing this patient here with, again, a low-grade. And I performed the surgery. I performed the surgery though in a specific operating room, which has an integrated MRI machine, so that as soon as I think I'm done with the surgery, technically with the head still open, I can obtain a scan. And that will tell me how much, how good the resection was. And in this case, for example, you can see with this blue arrow that there was a small portion of the tumor that was actually hidden and I had missed. And so that allowed me to realize that. I took the patient back right away. It just needed to bring the microscope back into the field. And that was like just 10 extra minutes of surgery. But that allowed me to eventually obtain a gross total resection. So again, there is a lot of different tools that we can use nowadays to really maximize this. This is probably the first fundamental goal of treating a new patient with low-grade tumor, which is providing an aggressive, a safe aggressive resection. So now the next thing at this point is that so surgery is done. Patient, thankfully, is doing well, is recovering postoperatively. Now the question is, obtaining a diagnosis which is as much as possible predictive of what the tumor, how the tumor is going to behave. And so this Dr. Klaus actually, mentioned that earlier in her presentation, but I really want to stress this because I think that this has really been the major shift in how low-grade patients are treated, which is the understanding that there are specific molecular features in these tumors that are really what characterize the tumors and how they behave. So this molecular evolution really happened initially in 2016 when there was actually the prior WHO classification. And for the first time, we went from a diagnosis which was just mainly based on watching the tumor under a microscope and really trying to figure out what were the visual characteristic of this tumor. Like a low-grade tumor generally had not many cells, the proliferation index was low, and overall a bland appearance, meaning that the cells more or less, they all look like alike. versus a high-grade tumor, which usually is much more aggressive. It recurs, it develops much faster, where cells are usually much more, the proliferation rate is much higher, and also there are specific patterns. What we have learned over time is that this is not necessarily always predictive, as sometimes patients that have been diagnosed with low grade by this old way of classification, their tumors actually behave more like high grades. And so now actually the way things work is that the tissue is really not looked much under the microscope, but is looked under the DNA sequencer. So basically, the tumor DNA is obtained from the tumor pieces, and then pretty much the entire genes are analyzed to look for mutation. And what a lot of smart researchers have noticed is that there are certain mutations that associate very closely, not only with a better definition of low-grade glioma, but also it's much easier to use this information to predict how this tumor will behave. And so today and the future, I mean, the future is probably going to be even more complicated, but I mean, as of today, this is really what we're looking at. You know, this specific, each one of the specific green spot here, for example, it says that these tumors here have this specific IDH1 mutation, which again is a very characteristic feature of actually a large group of low-grade tumors. This blue area here shows that all these cohort of tumors, they have specific changes in chromosome 1 and 19, which also means that these tumors are actually classified as oligodendroglioma, which is again is very important. So at this point, we arrive at this this classification, which, you know, I try to simplify it here, but I mean, in the end, this is really what it is. We start from a general idea of low-grade diffuse glioma, and then the first thing that we look at is what is the IDH status, if it is mutated or if it is wild type, meaning it's not mutated. And then within the category of the IDH1 mutated, then there is also the subcategory of the tumors that have the 119 chromosome co-deletion, which again, it characterizes them as specifically oligodendroglioma. And so why is this important? It's important because of this, and this is probably really one of the most convincing graphs that is available in the literature, is that, you know, these tumors are color-coded here. And basically, you can see that what probably before was still considered under a general umbrella of a low-grade glioma, see how different the survivals are for these patients, depending on either if they have both the IDH1 mutation and the chromosome 119q co-deletion, in this case, this blue line here, versus if they have the IDH wild type, which is here. So there is actually a threefold difference in expected survival there, which is really, it's really a significant change. And so this really has changed the way that actually we approach this patient. This is really just another little piece of information about still there is more that can be more information that can be obtained by molecular analysis of this tumor. And for example, this is how we can predict if a tumor will respond to certain chemotherapy. And tumors, for example, that have this gene MGMT that is inactivated by being methylated. But anyway, they will not express the gene. They have a much better response to the chemotherapy that is usually given to glioma patients. So, you know, to sum up this couple of slides, really, the take-home message is that so ADH1 mutation is good from a prognostic perspective, as much as the co-deletion of chromosome 1 and 19. And also this other molecular signature of having the MGMT methylation, which means, again, suppressed MGMT, is also a good thing because generally it will portend a better response to chemotherapy. And so it can also influence the decision-making about what is going to be the next step for these patients. So At this point, we are arrived to about 1 month after surgery. The patient has recovered. We now have all the molecular information about the tumor. We have a diagnosis, and so we have to decide now. The neuro-oncology and radiation oncology doctors, particularly, have to decide now what they're going to do next. And, while there is still some movement in the field as far as really trying to figure out for each specific situation what is going to be the best way to go, there are at least 2 situations where it's actually reasonably accepted at this point. This low risk situation, which is young patient less than 40 with reasonably smaller tumors that are IDH1 mutated and also 119q co-deleted. These basically went up and just being observed, like as we have heard earlier, because there is really no added benefit from performing, to add radiation or chemotherapy. For the other patients which are categorized as high risk, like patients older than 40, larger tumors, or actually probably more importantly, either IDH1 wild type or patients where gross total resection was not possible. In those situations, we start thinking about providing adjuvant therapy. And then what we know so far is that generally, if there is a decision about going with adjuvant therapy, there is some evidence suggesting that radiation and chemotherapy is superior to chemotherapy alone and possibly radiation therapy alone as far as overall control of the tumor. There is some, at this point still, it's uncertain when to do radiation, just for the concern of long-term side effect from radiation. But in these 2 specific categories, the best possible category and the worst category, which is this high risk with non-completely resected tumor, adjuvant therapy at this point is the way to go. Now, and I've heard that in the prior question, and I think this is really where I wanted to come, which is, so everything that I've discussed so far is standard therapy. So what we have enough data to say, okay, there is enough consensus that this is the way to go. Thankfully, though, one of the important things of this molecular approach is that it has allowed us to really determine a bunch of targets, a bunch of new genes that not only are important for for us to know, okay, these are the genes that make that are responsible for the tumor, but these are also genes that potentially can be targeted as a therapeutic, for therapeutic action. For example, this IDH1 mutation, what it does very shortly is that it creates an accumulation of basically a poisonous metabolite, which is called 2-AG inside the cells. And eventually this metabolite makes these cells go astray. And so they eventually accumulate a bunch of transformation in other genes and they become a tumor. So it was pretty obvious in the end that this IDH1 mutation would be an important target. And actually, I'm pretty happy to say that we are really starting to see some positive signals from this trial. We are not at level 1 evidence with big clinical trials, but there are definitely some early stage clinical trials showing that using inhibitors against IDH1, it actually, it has been associated. First of all, they're pretty safe and tolerated, but also there is clear evidence that a lot of patients actually respond to these drugs, and the tumor either stops growing or in some cases even regresses. There are other, for example, some inhibitors that target the BRAF mutation, which has already been tested in other cancers, and some, like a subset of low-grade gliomas, they do have BRAF activating mutations. And now there is this phase 2 trial which has shown that also these inhibitors are quite effective actually at stopping the tumor growth. And this is an ongoing process. There are actually several other clinical trials that are currently ongoing. And hopefully, for example, this Another RAF inhibitor trial will mature in the next couple of years. And so the field is kind of expecting some positive signal from this trial as well. There is a big now interest in immunotherapy. Unfortunately, I have to say that there is not been much as far as responses so far, but we are still at an early stage. Vaccines have been really the most used. But again, so far we are really stopped at phase 1 trials where it mainly shows safety and tolerability, but efficacy is really not particularly high. And also, still within the immunotherapy realm, the therapy with immunocheckpoint inhibition, which has worked great for other cancers like melanoma or lung cancer, but so far in glioma is really lagging behind. Now I just want to spend the last 2 minutes with this trial that actually we are doing in collaboration with our colleagues at UCSF. And we basically asked ourselves a question, which is, the problem with trials is that, you have aggregate data, but we really never know if a patient will respond the same way that you have seen responding, according to the clinical trials. So we asked our questions: can we somehow use the patient as his or her own lab to figure out which drugs will work best for that specific individual? And so in order to do that, we partnered with very clever people at the MIT, at the Massachusetts Institute of Technology. They actually have made this little device, which actually, as you can see here, is this thing here, this is in comparison the tip of a pencil. And this little device is actually filled up with multiple different drugs. Each drug has its own specific outlet. And so what we have done in our preliminary clinical trial, we insert these devices into the brain in the patient when he's in the operating room, and then we let these drugs go into the tumor, and then we can analyze each drug and see how it works. And so, for example, this is like a quick view of what we are doing. So there is a patient with low grade. In this case, we first do a needle biopsy, which is just a very standard treatment for this patient, just to figure out what kind of tumor this is. And then once this is done, we get these micro devices and we implant them into the tumor. That's still within the same approach for doing the biopsy. So there is really not much added on at this point. At this point, the patient, then everything is closed up. The patient stays 3 days in the hospital. During this time, the drugs are released. They go into the tumor. And then we take the patient back to the operating room, this time to do the actual surgery. And when we are there, we basically remove the piece of tumor which has these devices there. You can see these white things there. And then we send this for analysis in the lab while the surgery continues normally. And so what we have, this is the new way to do research, really, is that we have these tissue deriving directly from the patient, where we can actually analyze the diffusion of each drug, and we can actually also quantify how the drug really killed the tumor cells. And for example, we can figure out, for example, in this case, patient 6 here had a very low response to temozolomide in this case. And if you look here, this patient who ended up receiving temozolomide, he had a recurrence of his tumors within a few months. So basically, there was a very, very, very good correlation with what we observed in the device and what we observed in the patient. And on the contrary, this patient here, with the same tumor, in this case, this is a high-grade tumor, but the thing applies also for low-grade tumors. In this case here, the micro devices showed us a very good response to temozolomide, same drug. And this patient also ended up receiving the temozolomide. As a consequence, what we have observed in real life is that this patient actually responded to temozolomide much, much better than the other patient, than patient number 6. So we have already evidence that the signal that we see from these micro devices is actually recapitulated in real life in the patient, which is actually very encouraging. And here it is to finish up, showing that our idea is to basically, for each patient, come out with a list of drugs, and for this a repertoire of drugs, figure out which is the one that works the best. In this case, patient 6, again, temozolomide doesn't do anything. So why would we even bother giving temozolomide to this patient? Instead, for example, we could give this other drug here, which seems to have a very interesting response. So in conclusion, the point really that I want to make, which I think are important, is that there have been major advances in the treatment of low-grade gliomas, and they really impinge on the molecular understanding of these tumors. These, at the same time, have also allowed to start these new targeted trials with particularly IDH1 inhibitor and BRAF inhibitors, which are quite promising. And then, there are these exciting possibilities for personalized approach, which, in the era of targeted therapy, they're probably going to continue to explode in popularity over the next several years. The last thing that I wanted to mention here, this is really my last slide, is this, that, the reality, and I really realized this as I was doing this presentation, this is really a teamwork. It's the surgeon starts, then the radiation oncologist and the neuro-oncologist, they really take over after that, depending on the data that the researchers and the pathologists actually have given them through all these molecular analysis. So even the people that are a little bit more behind the doors, they are actually very fundamental to this process. And finally, the patients. The courage that patients have, for example, to accept to do these trials, like, for example, the trial that I'm proposing, why would you do 2 surgeries instead of 1, right? That actually tells a lot about the energy that is in this field. And so hopefully that will bring us to, to further development and success. With that, I really thank you very much for this opportunity. And if you have any questions, I'd be more than happy to answer.
Thank you so much for your presentation. Just as a reminder, if you have questions that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. One of the first questions we have here, Dr. Peruzzi, is about the image you shared about IDH mutation and methylation. Can you clarify again what each component means and what is considered good, quote unquote, or bad when it comes to IDH mutation?
The 2 things are actually go hand in hand very often. So it's IDH mutation and MGMT methylation. So there are 2 different genes, but the mutation of the IDH1, which is usually the starting, this is the starting event in low grades. It's like in 85–90% of the cases, it's associated with the MGMT gene methylation or inactivation. So the 2 things are really going together quite consistently. But sorry, the other thing is that the difference, though, is that the MGMT methylation, so MGMT, it's a gene that encodes a protein, and what this protein does, it repairs DNA after the DNA is damaged by either radiation or most likely chemotherapy. So what happens is that if this MGMT is present, then those cells are actually able to repair the DNA after chemotherapy, and this it makes that chemotherapy does not work very well for those cells. On the other side, if the MGMT gene is not active or methylated, which is the same thing in this case, if it is not active, then the DNA is not repaired, and as a consequence of that, the tumor cell dies.
Thank you so much for sharing that explanation and elaboration. Another question we have here is asking about if you're aware of any advancements or research that is being done to advance surgery technology. You talked about fMRI, interoperative MRI, and those techniques. Are there any other advancements that you're aware of that can improve outcomes via surgery?
Yeah, so I didn't mention neuronavigation because the neuronavigation has been used for a long time, and neuronavigation is basically just you can think of it as a GPS system for the brain, for the surgeon, so that you kind of know in real time where you are with your instruments, because the computer is able to see your instruments in the brain of the patient and basically project it in the MRI imaging. But this is definitely one it's a tool that we use pretty much all the time. The other thing, although for low-grade glioma is not as used, is the use of certain dyes that you can actually give intravenously to the patient. And so these dyes, they are not visible generally in the normal brain, but the tumor is able to metabolize them. And so that basically when you use a special microscope, you can see the tumor like red or green. And that allows you to actually see it, to actually see much better. And then finally, now there is some push on really trying to get some really cutting edge technologies to actually use specific probes that you can basically touch any surface when you are in surgery of the brain or the part of the brain that, the part of the tumor that you have resected. And those probes are able to give you in real time an analysis of the tissue. It's like having a pathologist there in the operating room looking at the tissue right away. And so it can really give you a very, very precise idea if that tissue that you're touching is tumor or if it's just brain.
Thank you so much for sharing that. It's really exciting to hear what's on the horizon and the advancements that are currently taking place. On that note, we have a question here asking, these advancements that you just discussed, is there any evidence or suggestion that they may be applicable or usable for people who were originally told that their tumor was non-resectable?
Yeah, so, let me first start with this. The concept of unresectable tumor, it varies. I will have to be honest with you. I think that this is some surgeons will consider unresectable. Other surgeons will consider the same thing resectable. I think that a lot of it has to do with what I mentioned earlier, which is how much you, as a surgeon, but also as a patient, how much are you willing to possibly, jeopardize as far as your function in order to try to achieve an aggressive resection? So this is the first part the first part of my answer. The second part of my answer is yes, these tools clearly help in really trying to maximize safety. As long as you can perform the surgery safely and you can have a constant feedback of what's happening with the function of the patient, you'll be surprised of how much we can really remove from tumors, even in areas that are not necessarily very easy.
Thank you so much. I think we have time for one last question. We have a couple of questions here about brainstem gliomas, which we know can be a difficult area to resect. Are you aware of any advancements in treating brainstem gliomas? Yeah,
so brainstem gliomas are, yes, a very difficult situation, particularly, they are generally more like towards the high-grade spectrum of this disease. The treatment there remains still. I cannot really quote studies that convincingly have shown progresses in that area. There is, for example, there has been the use of convection enhanced delivery, for example, right? So by definition, a brainstem glioma is a glioma that you really cannot resect, but you can still reach with some probes, like the same, very similar to the biopsy probes, but you can use these probes to actually pump in chemotherapy. And what this does is it allows it facilitates the diffusion of the drugs into the tumor. There are some conflicting, there's some conflicting evidence, I would say, as far as how effective this is. But this is certainly a direction that we're going for.
Great. Thank you so much for that question, that answer. I think that is all the time that we have for questions for this session. As a reminder, if you have any additional questions you want to ask, please continue to submit them and our speaker will try to answer questions after the session. I'll go ahead and turn it back to Emily to move forward with the rest of the program.
Thank you.